Hi, all. Thanks so much for watching Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta, and today we are welcoming Rob Alterman, who is the Chief Performance Officer at Guidehealth, and Dr. McKay Crowley, who is the Chief Health Officer at Guidehealth. Thanks so much for being here.
Thank you for having us.
Thanks. This is a pleasure.
What is it about Guidehealth and your system or your process, your technology that allows you to get quick wins in ways that other technology might not, or ways that a traditional system might be operating?
I think to a fair degree, that's a great question. There's a few things that I think I should hit on, but what governs all of it, in my view, is just simply how targeted and efficient we are in all of our work day to day. We, for better or for worse, much of the last 10 to 20 years story of value-based care is either a very brute force, call every patient every day, all the time kind of model, or more commonly, a uh, send physicians an overwhelming number of lists and expect them to call the patient all day, every day kind of model, them or their staff. I think one of the things that Guide Health is very good at is identifying who needs what intervention or what assistance, when they need it, by what channel. And we use human and AI constantly in concert, I think, to help extend that staff and optimize that channel. And then taking that intelligence and bringing it in partnership to our health system clients so that they can operationalize it, frankly, in their own footprints as well, and just significantly ramp up the efficiency of the entire collective.
You hit on two kind of crucial points there, Rob, that number one, and we've really adopted this as a philosophy in Guide Health, that the perfect list in value-based care for primary care physicians is no list at all. So many physicians will tell you that they can't do one more thing and they're right. And managing a list that helps them be successful in a very small number of attributed patients really falls either off the desk onto the floor or is so far down the priority list that they can't get to it. So I think that's number one, is that we did not take a list to any of the physicians. We took tools and humans to do the work for them to fill those gaps. I think that number two is we are able as a partner for our health systems and Emory in particular to be agile and nimble and say from one day to the next, this is working, let's do more of it, or this is absolutely not working. How do we change it so that it does, or get rid of it? And that was the philosophy that we took into these early win conversations.
I'm really intrigued by this model that both of you are describing, and actually have a follow-up question along the lines of quick wins. Because, everyone talks about quick wins, and you think, well, if the quick wins are there, why can't just other people identify those quick wins and go after it? But actually, the way you describe the model is really brilliant because it's the mechanism of your own solutions through which you're able to identify, I think, what quick wins could be. And that it sounds like an individual health system is really not going to be able to just chance upon them on their own. And you're kind of coming in that sweet spot between being too overwhelming to that individual physician, as well as just kind of trying to do too much work, on your own. So I love what I'm hearing, but please elucidate if what I'm capturing is correct, and again, the value proposition that you have in helping health systems identify the quick wins.
We certainly go in with the art of the possible um, and with no complacency. Any any organization at all can slide into complacency year over year. You turn around and it's gone from January to September really fast. With no appreciable movement to get to that quick win. We were able to identify where those areas are, create a sense of not just a sense of urgency, but also a toolbox of tools, both consultative and vendor type platform tools to move into those quick wins and change the sense of urgency within the organization.
One of those quick wins we identified was on that contract Makai was describing, the controlling blood pressure measure, the standard HEDIS measure around, blood pressures under, compliant reading levels. When we started work on that contract, there were a little north of 2,000 gaps. And I'm not sure how many health systems have the RN capacity to call patients until you've closed 2,000 gaps in 90 days, or even for those that have it, whether assigning that many RNs in that much time to do that work is actually the right use of a nurse's capacity. So one of the things that Guidehealth genuinely does that I think is meaningfully different is we can go in and say, let's let's skinny this list of gaps and focus nurse time on only the things that really matter. Some number of them have already been closed in your EMR. They just haven't dropped on a claim yet. We'll help you extract that, package it, and send it in through a payer compliance, supplemental file. Some number of them are from people who already have home cuffs and could do a patient, a home reading at home and submit it, and it'll be CMS compliant. And we can spin up an AI agent that will call them and walk them through it. And then some number are going to come back with blood pressure that is genuinely higher than we want it to see. And if we can get those patients connected with your nurse care managers, that frankly is an effective use of their time, a much better use of their time, and allows them to spend a lot less time auto dialing, talking to voicemails, and or talking through basically the worried well, and focus their attention really on patients who genuinely need their help. And it's a much smaller number.
From an operational perspective, we can also deploy, in particular, our AI tools at times of the day and at volumes that have heretofore not been accessible to health systems. So, I can deploy a blood pressure AI agent for 1,000 calls at 6:30 in the evening, when patients are more likely to answer their phone and be at home where their blood pressure cuff is, and have those results ready for staff at 8 o'clock the next morning when they come in to manage those um, have to those patients who would really benefit from a case manager.
And so, what have some of the results been, both from patient engagement and feedback after they maybe feel more supported by being contacted in the times that are appropriate for them when they can take action on their health? And then on the actual measures for the blood pressure, how did that, you've mentioned that you had 6 different measures, that you were 4-star. So tell us about some of those and how that all played out.
Sure. Maybe I'll start with the overall view of the contract. So that's right. We targeted 7 measures that were, of which, when we started, one was at 4-star and the rest were at somewhere between 1 and 3 for the most part. We finished the year with that 4-star measure going up to 5, and the rest, 5 of the other remaining 6 clearing 4. So we basically triggered quality incentive payouts on 6 of the 7 addressable measures that were within our scope. The target when we went in was 5, so we actually overachieved that goal. And generated pretty material revenue for our client, and then obviously ourselves. And I'm glad you asked about engagement rates, because I have to confess, going in, when we said we're going to make this AI blood, we're going to use this AI agent to call and get patient reported blood pressure readings. There was definitely a moment back in like September, October, where I called McKay and was like, "Be real with me. How many people are going to pick up the phone and talk to this thing?" The answer is a lot. By the way,
Yeah.
I thought it'd be 2 or 3%. The numbers we consistently see are 10 to 15 times higher than that. From when people pick up the phone to when we complete a successful call. Yeah, 10 to 15 times roughly higher than that. And that point now, we've replicated that across medication adherence, across cancer screenings. I mean, there's a dozen or so permutations of these different kind of use cases that we have out in the field actively today. And consistently, we see those engagement rates that are just, fabulously high.
Yeah. Patient adoption has not been, it was an initial concern, has definitely not been an ongoing concern. And as the patients have adopted this new technology, we've seen the physicians come along behind them and say, "Oh, okay, if our patients are okay with this, what can we do more of, and how can we be more effective with this tool?"
This is what our show is about, making healthcare work for you, and you're making it work. This is incredible. Patients are using it. The physicians are now willing to come around saying yes. That's remarkable. So I guess I have a two for a question. Hopefully that's not unfair. One is, what do you wind up doing with those patients that never respond after two, three, four, five calls? Is there still a mechanism to try to reach them, or do you just say, well, we're going to leave those alone, or is that when a nurse steps in? So that's one part of the question. And the second is, in addition to the response rates, do you have feedback from patients as to how they actually like the system, feedback from physicians themselves as to how they like this overall approach?
We do a numerical rating system, kind of a survey at the end of the AI calls, and consistently around 9 out of 10-ish satisfaction rating on those, or NPS rating. Patients like them. We talk about merging AI and empathy with our company. And what I realized, what clicked for me was the AI agents are absolute bottomless wells of empathy. They're not on the clock. They're not trying to get to their next call because they're stressed about how much, is already on their plate. They're not worried about what's going on at home or texts from their kid's school. Like, they are there present for the patient in a way that is really quite impressive, actually, frankly, when you hear it live. And then I think to the first part of your question, what do you do for the unable to reach patients or the challenging to reach patients, which is a great question because anybody who's looked at a value-based care P&L knows that that's where you kind of lose all of your money, are the ones you can't get in. We have found a few different tricks that work to get our unable to reach rates up. McKay talked about varying the hours. That's certainly one of them. But I would say we've also had a lot of success trying what I basically think of are like agile marketing principles, stuff you would use to sell credit cards or shoes or anything else in many ways, to drive engagement, and treating it basically as a marketing problem. So for example, classic care management workflow, call a patient 3 times, mark them as unable to reach, and move on, right? A model where you call them 3 times, send a text saying who you are and that you are going to call, and then call a 4th time within 24 hours of that text, we find that you'll consistently get 40 to 50% of those patients on the phone. And for care management, you'll engage. Some will turn you down, but at least you know the answer, right? And plenty of them, about half of those, maybe a little bit more, actually will consistently engage. So there's all sorts of little tricks like that if you treat it as a marketing problem that we have found that have cumulatively made our engagement rates, we believe, quite a bit higher than industry averages.
Oh, fantastic. McKay, anything to add to that, or did you think Rob covered it?
No, I think Rob has covered it. The only thing that I would add is um, the clinical staff that we have doing outreach and providing care management, et cetera, has really found it liberating. And I think this is the other really important side of healthcare is how do we preserve and leverage our existing clinical staff. They found it very liberating to think these ways and to be able to be creative. And so we're seeing such incredibly active participation from those case managers, from our physician office staff in how can we be more creative. And it's been, after kind of the doldrums of the last number of years, it's been great to see kind of that renaissance of thinking, if you will.
It feels to me like a lot of people worry with technology, with AI agents, that ultimately they get threatened by them. They feel like they're going to take their jobs. They feel like, wait, how can the bot be an endless well of compassion? I'm supposed to be the well of compassion, but yet you're finding that that's really different. That you're finding tremendous uptake and engagement. So I just love to gather any more insights you have on how you helped the team members, the staff themselves, the case managers, the physicians not feel threatened by this and really see this as as a supplementary to their efforts.
I'm really glad that you asked that. I'm actually doing this interview from a stairwell where I'm doing an offsite with my clinical staff, and we're addressing just those things. Um, the I think it has got to be an active, ongoing conversation I think everybody right now, if you look at what's in the public media, there can be a sense of dread of, of that encompasses insecurity about, future job state, et cetera. We really encourage both our employed staff as well as our partner staff to think about what can only a human do, and how do you engage this tool of AI to make your job and your relationship with that patient better. And really, it literally is a daily conversation to make sure that you understand what everybody's fears might be, and to continue to engage that creative streak that they have, so that we are innovative with the tools, and people feel like they have agency in their future.
To me, one thing that's true of physicians, nurses, and case managers, one thing they all have in common is they are fundamentally workforces for which there are too few people who are saddled with way too much work that is frankly not an optimal use of their time. I think the hay to make or the wood to chop on AI, and there is a lot of it, is in how can we automate or take away or and give to the machines much of that work that frankly does not require human judgment, and then, like you said, feed them, feed the people the things that frankly require a trained person, of which there's also no shortage.
It seems as though the work that Guidehealth is doing really is transformational in making value-based care happen, which has been something that people have been trying to make happen for a long time, but some people really thought was just an impossible task. So what do you think of what you're seeing, the results that you're seeing, the partnerships that you're getting, that gives you hope that this can be a scalable change across the entire industry, not just something that a few limited systems might decide? What can make healthcare
Yeah.
truly change?
I'm so glad that you asked that. So I've been involved in one form of value-based care or another for the past 30 plus years. Um, I bring to my staff and my thinking and my relationships with our clients and partners every day that we can't do what didn't work in the past harder and make it work now. So what innovative things are we going to do today that are different to make those changes apparent? And again, the rapid iteration of this worked, let's refine it and make it better. This didn't work, can we fix it and move it forward? Or that didn't work at all, let's trash it and move on. Has got to be a part of everybody's everyday operating framework.
Thank you both so much for being here. That was fantastic. I really loved that. I loved the don't do what's not working harder. You can't doing the same thing isn't going to fix it. I love that.
That's right.
Thank you both for being here. This was tremendous. We love hearing about what Guidehealth is doing because it really is making a true change in the industry.
Great.
Thank you again for having us. Truly a pleasure.
So fabulous. Thank you.
Thank you all for watching. We'll talk to you soon. Bye-bye.